I wanted to talk about like how do we think about the use of medicines in the treatment of kids on the spectrum, because certainly many kids on the spectrum don't take medicines, and that's an important place to start, that there's often behavioral therapy that we're working on before considering medication. And it's a difficult decision. Many parents have told me to, come to a decision of like, how do you weigh that out? And that's what we really want to think about tonight. Like, where is the place of medicine, and what are some of the big principles that are important in considering that? And then what are some of the individual medicines that could be helpful to kids on the spectrum? But I want to leave plenty of time that if you have specific questions that you think would be useful for the whole group to hear about, that we address those. So is everyone getting a handout then? It's coming out there? Okay. So as far as the big ideas in considering medicine for kids, is the first thing is, I think there's no specific medicine for kids with autism. Like it's not like ADHD, where we can say if your child has attention deficit hyperactivity, then there's a specific medicine for that. Obviously there's behavioral strategies as well, but that's like one of the most medication responsive problems that a kid can have is ADHD. There's a specific medicine for depression, there's specific medicines for anxiety. There's no specific medicine for autism per se, but there are many problems that a child may experience that could benefit from taking medicine. So that's what we want to think about for each child. What are the specific problems, and could medicine be, weigh out as any risks or side effects of the medicine are outweighed by the potential benefits? So some of the symptoms that we'd be thinking about would be, just like kids with ADHD can have inattention, certainly kids with autism spectrum disorders can have inattention and hyperactivity and impulsivity. In fact, many do. It used to be, well, and still in our diagnostic manual, and actually I was going to touch on this today as we were talking about things, that there was this big controversy that was on the front page of the newspaper, and people were thinking about, like, what does this change mean? And I thought it would be helpful maybe to say a few words about that. And we'll have something posted on our website as well, where I talked a little bit about that. It was on the news this week, but the news stories, I think, only go so far into it and don't necessarily explain what's actually happening. So did people have questions about that? Like, what does this diagnostic change mean? I'm seeing some heads shaking. Yeah, like, what does it mean? So, I mean, some of the things that came out in the news where people were like worried, like this is like sudden news or something, or they just put this out here all of a sudden and they're not giving a chance for, comment or questions or rebuttal. And yet it's really not true. Like, these DSM-5 changes have been posted online for a long, couple of years now. Like, we've had access to them, and not just clinicians or researchers, but everybody has had access to them, and you can see them if you go to dsm5.org. You can read like what are all the proposed changes, like what are the diagnostic criteria now, what are the proposed changing criteria, and like what's the rationale behind it. Like, there's tabs for all of that to read like what's going to happen. And so the proposed changes for autism, right now the way the diagnostic manual reads, there's a big category called PDD, pervasive developmental disorder. And within that category, there's one called PDD-NOS, which is always confusing. Like, what is PDD-NOS compared to atypical autism, compared to high-functioning autism, compared to Asperger's disorder? Like, what does that mean? And it turns out that like any one kid diagnosed on the spectrum is more likely to get one diagnosis or another, depending on what institution they go to, or who diagnoses them, as opposed to who that child actually is, or what his or her needs are. So really, the proposed changes are designed to clear that up, so that not only parents, that it's more understandable, I think, and not so confusing for parents, but perhaps even more importantly, that clinicians and researchers are all speaking the same language. That when you say something, everyone would know what you mean, as opposed to, depends on where you went, and that's the diagnosis you got. So right now, within that category, one diagnosis is autistic disorder. And this has been a confusing thing. And I know I have done this myself, like years ago, that if a parent was wondering, what is my child's diagnosis, I might say, well, he doesn't have autistic disorder. He has something called PDD. And then what the parent hears is, my son does not have autism. Like as if PDD isn't autism, but it is. So it's like one thing. It's just a spectrum of like where the symptoms are, and the symptoms could be more severe in one area and milder in another. So that's what the new changes are designed to pick up. And basically, I don't anticipate that they're going to exclude anybody from the spectrum, or if that does happen, that would be rare, and probably then the kid or adult in question may have been misdiagnosed in the first place. And so that they'll be better served if they have a proper diagnosis, like what actually is happening. So right now, the diagnostic criteria, I'm sure people are familiar with autism and what the symptoms are, but just briefly, there's 3 categories of symptoms. There's language and communication, there's social behavior, like going back and forth and having friends and reading nonverbal cues and all of that. And then there's restrictive and repetitive behaviors, and that would include, intense interests, unusual interests, repetitive motor behaviors, and the sensory problems of autism. So the proposed criteria doesn't actually get rid of anything as much as it collapses the social part and the language part into one category. So one of the misconceptions in the news stories was that the diagnosis was narrowing, or that it's as if you had a long menu that was being shortened. Because essentially what they've done is taken parts that fit together and should have been together probably all along and putting them together so that it's more coherent. Because if you think about it, it's really hard to separate language from social behavior. Like they're really intrinsically intertwined, and oftentimes we'll find ourselves thinking, well, should we put that in language or should we put it in social? Like looking at specific things that are happening with any one child. And if you put them all together, like for instance, if you're thinking about a child who doesn't play very well, like back and forth or imaginatively, is that a social problem or is it a language problem? Because you have to have the language to support the play. You have to be thinking, what's happening next, and what does mommy say, or what is my character going to say next? You have to have the language to carry the scheme of the play. So really those things belong together and you can't pull them apart. So in the new diagnostic criteria, there will be, within the language and communication section, 3 symptoms, and you must have all 3 in order to meet that part of the criteria. And the 3 things are the back and forth part, like the social reciprocity, and each one of these will have a spectrum within it then. So it might be that you absolutely have no ability to do that, and you don't even approach other people, like you're very much to yourself, all the way to someone who just can't quite know how to take turns in a conversation. So that is a really wide range. And then the next one is the nonverbal behaviors. So that would be things like making eye contact, using facial expression, coordinating eye contact and facial expression, and gestures, and all all of the nonverbal parts of communicating. And so again, that goes all the way from not quite understanding that, like how to use your eye contact appropriately, not gazing a little too long, or not looking enough, to people who don't make eye contact at all, or really have a blank facial expression. So again, it's a wide range of a little bit off on the facial expressions to really just not using them at all. And then the last part is relationships. So again, spectrum. So no interest in relationships, no friends, all the way to having some problems understanding the hierarchy of things, or that you don't treat your teacher the same as your mom, like that kind of thing. Like that, it's a wide range. So and so there's that language, communication, social piece, and then there's the restrictive repetitive behavior piece. And that one does have some choices, and you have to have 2 of them, and it includes all those things you would think it was, like the intense interest, the unusual interest, the repetitive motor behaviors, and the sensory problems. So you can see that, I know in diagnosing kids, I've been thinking about both sets of criteria for every single kid that we see, and the same kids end up on the spectrum. The other thing that the new criteria will have is kind of a mild, moderate, severe. So they're calling it level 1, 2, 3 of how severe the social language problems are and how severe the repetitive behaviors are. So then it will help us understand, like, well, this is a kid with mild social problems and pretty, moderate to severe repetitive problems. So we really have to address that piece better. Because right now, if you can imagine, if someone at the Board of Ed hears my child has a diagnosis, no one knows exactly what that means right now. If with this, if you say my child has a and the other parts that I didn't kind of get into is there's going to be with or without language impairment, with or without intellectual developmental disability, and then the kind of other things that could go along. ADHD. Like you will be, like in our current diagnostic manual, you're not supposed to diagnose autism spectrum and ADHD at the same time because you'd be diagnosing so many kids with both. I, as a clinician, believe in making that diagnosis when it's really clinically relevant. Like, because there's some kids who are inattentive and it's always going to be something we're thinking about and doing something about. And then there's kids who really are so unfocused that they're not learning, and they're not paying attention at all to social things. And then it's really like a big focus of clinical attention. To me, that merits another diagnosis. It's like over and above. In the same way that sometimes right now, even though language problems are part of autism, we'll sometimes diagnose a separate language disorder because the language problems are so much more prominent than any other symptom. Then that makes sense because we want to highlight it and say we need to be really addressing this. So I think you can imagine if instead of getting his PDD-NOS, if the Board of Ed got this is moderate social, child on the spectrum, ASD, moderate social problems, severe restrictive and repetitive behaviors, of course they'd be described, and without language impairment, without intellectual disability. We go to bat for many families about that. I've certainly been on the phone, in the IEP meetings, talking. Basically what we have to say is how is this intellectually, educationally impairing for this child. And so, for instance, I can remember being on the phone of a kid who's, he's a bright boy. He wants to have friends. He loves to be around kids. If he does not get to say morning prayer, gone. Not ready to learn anything the whole rest of the day. The only thing he has in his mind is, I didn't do morning prayer, I didn't get to do it, I didn't get to, cannot think of anything else. Well, he is educationally unavailable then. That's educationally impairing. We need to understand that for what it is. That's not oppositional. He's not. If he could do it, he would do it. He just can't do it. He needs, a better plan. And he needed medicine in his plan, so we'll talk about it would fit nicely into this story. Maybe I'll continue this theme through the story, actually. Not necessarily, but you're right that and that's why the diagnostic manual didn't want, it was decided not to make both diagnoses because of so many kids being diagnosed. But I will say I've certainly seen kids who are on the spectrum who I wouldn't necessarily give them that diagnosis. They have some problems with executive function, with paying attention, but it's not keeping them from learning. It's not the biggest thing inhibiting their social functioning. Like other, more like deficits in being able to do it are making it hard for them socially, and they're not so impulsive that they're, crossing boundaries. There's just not that same physical restlessness and such that a lot of kids have. And I think in those kids, I would make both diagnoses because they're meeting full criteria for that other disorder, and it's a big clinical focus. Right, and I think it's good to have a doctor that you trust and a therapist that you trust and a good treatment team who can help coach you through that because, the little boy that I was talking about, certainly they wanted his classification to be other health impaired, which, it's fine. However, it didn't have the services that he needed. He really needed an autism classification, and that was the most educationally impairing problem that he was having, and it made a lot of sense. And I had, on the other end of the phone, I had the comment from the chairman of the committee. Autistic? He can't be autistic. He's not sitting in a corner banging his head against the wall. Yes. But anyway, I just plow through that, and I just keep making my point of this is what's educationally impairing for these are the symptoms he has. This is how they're educationally impairing. I don't lose my temper. I don't ever look shocked. I just say, okay, this is all right. Okay, and this is what he needs. And this is what's educationally impairing for him. Oh, wait, by the way, these are his symptoms. This is how they're educationally impairing. This is what he needs until, and they have another appointment, they have another, I know, they have the realities of they have so many meetings today, and I have sympathy for them on that. And yet, and the meetings that sometimes I'm on the phone and sometimes I go to the meeting. and I sit down in the room and I say, okay, this is what we're doing. We need to do this. It's just hard. Yeah, sometimes it's hard. I don't, I'm not saying it's an easy task.
No,
it's a lot to know, and you need someone helping you to know, okay, this is our agenda, this is what we need to do, these are the points we need to make, and it's not okay for school to say you need to medicate your child for them to be in the city. That's not their decision to make. It certainly is your decision as parents, and that's why we're here. I'm talking about medicines and being able to think about that together. So I think being able to have an open dialogue with I'm a child psychiatrist, so I'm one type of medical professional who could be providing medicines for children. There are others who certainly provide medicines to children on the spectrum. That would include developmental pediatricians and pediatric neurologists. So, and I think regardless of those specialties, that each of them would still have to have experience in children with autism, because just being a child psychiatrist doesn't mean that you have experience in children with autism. And I think you have to take an interest. And I took an interest years and years and years and years ago as a medical student at Northwestern in Chicago, and I met a little girl who had autism. She was 2.5, and her parents had just arranged, a psychologist had just come from UCLA with Lovaas, and was, this is in 1992, and doing ABA therapy, and to me, it was nothing short of miraculous to work with this little girl who went from no language at all. I mean, she was clearly I was a med student. I didn't have a big knowledge base at that time. But watching this little girl go from no language, spinning, looking at her hands, to a vocabulary of 2,000 words, and just really very, very interested in interacting with us. And I'm not saying she wasn't autistic. She was still very much autistic. And she had a whole world that opened up to her of language and communicating and playing with us. That was just amazing for me to see. And I thought, wow, I want to know more about this. And I quickly figured out that not every kid, had this, huge uptick in language. And yet, I was certainly made a believer of behavioral therapies at that time. So, having, that's why I started out saying that. Clearly, for many of problems, behavioral therapies will give us a lot of headway. It gives a lot of headway in decreasing interfering kinds of behaviors like tantrums and that kind of thing. Like, we can certainly look at behavioral programs for almost any of the problems that I'm talking about today. And yet, sometimes despite the best of behavioral programs, we still have a significant amount of interfering symptoms. And so it's important, I think, to be able to understand what could medicine offer, and that you guys are informed so that when you're going to talk to your doctor, I think that there's certain steps that you can take, so we'll talk about that. Like, what can you do to be the best informed possible, to manage this information the best, to have a productive dialogue with the medicating physician. And I think one of the things that perhaps is missing sometimes is parents just being very direct about what are their concerns. Coming in and saying, to me it's always wonderful. The parent comes in and says, okay, listen, this is where I'm at exactly with this. This is what I know so far, this is where I'm at with it, these are the questions that I have, because we really have a place to start. Because otherwise I'm trying to gauge, okay, where are we with this? What are the problems? Obviously I'm going to find that out anyways, but I don't know where the parent's head is as far as what they know already and what concerns they have and what questions they have. So the parents would come in really open about that, what I found out and what they know already, and what they're scared about, or what they're really most concerned about, or what they really hope to get out of it, and have really thought about that and are really clear about it. We have a much more productive dialogue right from the very beginning. Well, it's a little hard to say, however, because the problems can, just like I said, all of these autistic symptoms can have a range, all of these behavioral symptoms can have a range too, like inattention or impulsivity or anxiety or depression, ritualized behaviors. All of those things can really range quite a bit. And some of them, it's not just the symptom, like a certain symptom is particularly responsive to behavioral therapy. It's within this child, this set of symptoms, and his personality, his makeup, everything interacts. But I would say, if I just had to gauge like the number of kids that I see for evaluation, or maybe like I may see children in an ongoing way, like every 6 months, every year, even every 2 years, depending on like what their development is like, or like who else is involved in their life. That there's a significant number of kids that aren't on any medicine at all that I'm following, and then of the kids that I follow that I'm not just seeing for evaluation, that are coming back regularly, a significant number of that are coming for regular visits are on medicine because that's why they're coming. They're coming back to me for that reason. So if you look at the big group, maybe it's half. Maybe it's fewer than half. I'm not sure exactly that number. I mean, this is like my estimate of knowing kids that I know. But of the kids who are coming back more frequently, it'd be a much higher. It'd be more than half, certainly, because that's why they're coming. In the preparation part, and I put some notes here for this, just so you could be thinking about, like, getting ready for a visit, having all your ducks in a row as far as, like, looking back through your old reports. Like, I find when parents have really gone through and, like, looked back at old notes and, looked for, like, I'll often ask parents to print out, like, everything the pharmacy has filled in the past 2 years, just so we know. Because they'll say, really? He was on Focalin? I don't even remember that one, which may mean that they filled it and never gave it, or it may be that they were on it very briefly and they had a bad reaction to it or something. But it's good to know these things, and we can kind of like dig through information, like we want to know what happened in the past, so we're not repeating mistakes, or like we know if there was a partial response, maybe that points us in a different direction, helps us understand something. So gathering information and reviewing it very thoroughly really helps. Talking to everybody who's involved in your child's life, so making sure that once you arrive, you've already talked to the teacher, the coach, any therapists who are involved, like what, and usually what I think is helpful is to say, well, how are things going overall, like, to the professional working with them or the coach or the teacher, what are the biggest concerns right now, like what biggest concerns you have right now, and what's going really well. So we want to make sure that we capitalize on what's going really well too, or think about like, well, why is it that that's going so well? So we're thinking very comprehensively. And then when you think about symptoms, I often see parents kind of struggling to think back, and if I'm asking these questions in the visit, like, well, how often is this behavior happening? Like, suppose the behavior is aggression. There's really big, a wide range of like how much aggression can be, like how severe it is. Like, there's children who are either injuring others or injuring themselves. Like, they really have injuries, to kids who, they have a tantrum and they might lash out occasionally. Like, it crosses a line, certainly we want to do something about it, but it's not at all like the constant threat daily of injury. So how often, how long, how severe, in what context? So thinking about thinking like a behaviorist, like what are the antecedents to behavior, what's the actual behavior, and what are the consequences? Like, what happens after? Is there long discussion, or is there something that may be inadvertently reinforcing that behavior? Like, we think about all of those things. But also, just if I'm, just not just from a behavioral perspective, but if we're looking at medicine, I want to know, I want to quantify, like, what's happening here, so that if we do something, like, what if we start something and it's not so clear it's a benefit, but it's actually a 25% reduction? Well, that might mean we're on the right track. Like, we want to miss that because we might keep down that pathway longer before we don't want to keep switching. And I've seen that. I've seen kids who have come to me, and I've seen that too. When I'm looking at if I'm not careful enough to step back and think, wait a minute, what's going on here? I might make a switch, like that I look back on later and say, wait, that was too soon. I needed to have done something else. So I like to always be thinking along those terms. And knowing your own feelings about it, like talking, thinking through like what your experiences have been, so you can talk about it. Having a list of everything, not just the medicines that your child's been on, but all the over-the-counter stuff. People forget sometimes that some of the supplements that are being given actually have things that could be pharmaceutically active or interacting with medications, so something to be really careful about. And then, I gave a list. I won't read through all of these, but you have it in here. Like, if you've gone through this process and you're deciding to start a medicine, it's really helpful, I think, to think about like, what's in the medicine's name, obviously, but what's it, like what are we expecting it to do? And when I'm thinking about that, I'm often thinking about main effects versus side effects and that balance. Like, so we want to have clear main effects in mind. So if the problem is impulsivity, I want to first to operationalize that through those first questions, like in what context is this occurring? Is it all the day, all the time, just impulsive, like no matter what's going on, or is it is it in certain situations that we have impulsivity, and what does that look like? How severe is it? Like what is our definition of how are we going to know it's better? Like how bad is the impulsivity if we're tracking that, and how do we know it's better? So I often get calls late at night. We may go over all of these things, but I often get calls late at night like, we forgot to give the 6 o'clock medicine. Do we still give it? It's bedtime or it's midnight or something. What do we do? Or we forgot in the morning. Like now, what do we do? Do we just give the regular dose tomorrow? Like it's always good to try to avoid the midnight panic. The other dramatic one is usually child is screaming in background and mom and dad have both given the medicine dose, and the kid's saying, "I'm gonna die," and I say, first tell your child he's not gonna die.
Good.
That's thing one, not dying. Yeah. So we have to make the plan for what if you took 2 doses? Like, do we need to do anything or watching anything, or what do we do tomorrow? All those things. But nice to have some idea of those things. About what the side effects are, and those main effects of what are the potential side effects, how severe are they likely to be, how likely are they to happen, which ones do I need to call you for, which ones can I just watch for a while or tell you about at the next visit, so you're just really clear about that, in watching for it. How about, avoiding giving anything? I often get those calls too. My child has runny nose, he's really, usually it's when they're really congested, they're just socked in. And trying to figure out, can you give anything along with medicine to, relieve this, terrible pressure in the child's head, that kind of thing. Because, Sudafed, it doesn't actually interact with so many things that a young child may be taking, but certainly it can heighten the effects of stimulating kinds of things. So it certainly can be a problem. And some kids tolerate it and others don't, for instance. That would just be one example. And if you decide to stop giving it, or if you're not happy how it is, what about that? What's going to happen if you just stop giving it suddenly? I would advise you always call the doctor if you're thinking of any change, not giving the medicine. I sometimes have parents come in and they've doubled the dose since the last visit or something. Well, we didn't talk about it. Well, it seemed like it was. Didn't you say that? They'll say, didn't you say give them 2? Well, and I say no, we didn't. But so making sure there's a really clear discussion. And then the record keeping. Sometimes parents will come in and they have these lovely spreadsheets of every medicine, every dose, the duration, the peak dose, what happened, what the side effects were. It's so amazing to have this database of what happened. If we just went, if we have one big target symptom, or we go through 1 or 2 medicines and we nail it, not an issue then. You remember what happened. If some children, have several target symptoms, there's a lot going on, they end up on complicated things have happened over the last 5 years, it all fades away. It's just not there. I wouldn't expect you to remember it. So having some notes to go back to that have that, I wrote it down, what I would put on there, that ideal record of the actual name, dose, how long, the peak dose, how long they were at the peak dose, and what happened, both beneficial and negative. And keeping a nice notebook of here's the IEP, here's the most recent neuropsych, here's any behavioral, anything that nicely divided. It's lovely to have if you're trying to really get a comprehensive picture and figure things out. So if people don't have questions about that part, I was going to move on to the part about talking about medicines, and then we can talk, answer specific questions about medicines. What I did is I kind of picked the 3 biggest categories that we usually use that seemed like that would be the most informative for more parents. And as we've been talking about, one of the first things that I often hear for a child is that they're they're not paying attention, they're not focused, or they're impulsive, and that's really, and it's getting in the way of their learning. And I usually think about that in the same way that I would for a kid with ADHD, as far as like whether to use medicine or not, and that's whether or not those specific behaviors, like being unfocused or being hyperactive and impulsive, are actually getting in the way significantly of a child's functioning. So, and whether or not that child has crossed any one of three thresholds, and those are that the lack of focus is so great that the child's not learning to expect it. Like we've done intelligence testing, and the child clearly is capable of learning, and they're not learning to that expected rate. There can be other things interfering there, but if focus seems to be prominently interfering, then I would think of that. Then the next focus one is the social piece. Now, obviously, this is already an issue for kids on the spectrum. So if they are either so unfocused that they're just not even present to get in social information, or they're so impulsive that they're always crossing boundaries or calling out in class, doing the same things that kids with ADHD do, and that's getting in the way of them functioning in the classroom and learning and functioning socially in the classroom or outside of the classroom, then I consider it there. And the third one is basically their concept of themselves as a kid, and if they are so impulsive, either so unfocused that they're not learning and they're starting to think of themselves as stupid and they're not. They're like an intelligent kid who can learn, but they don't even know what the teacher said. So how could they possibly know what the teacher's asking them? And then they start, saying that. You'll hear children come home, and say, I can't do it, I don't know, I'm in the low group, or I'm, kids call me names about that. Like they start to think of themselves in that way. Or they start thinking of themselves as a bad kid. Like they're always in trouble, they're always being told no, don't, stop, like being yanked away from something because they're too impulsively going towards it and they can't really help themselves. And no one of those would mean medicine for sure, but I'm thinking about all of those things. Like how a lot of kids have symptoms, but they don't necessarily need medicine. If they're really having this degree of problems, that's when I start to think, wow. Certainly put in behavioral strategies, do all the things that we can do behaviorally, and that's the focus of another talk. But I'm really thinking about the psychostimulants. There's specific things to think about kids on the spectrum, and this is why I was saying that you really need a specialist who knows kids on the spectrum, because lots of kids with ADHD respond to medicine. It's not easy every time, but 90% or more of kids are going to respond to one or another of the psychostimulant medicines. So for kids with autism, that's probably more like half. It's not, which is still a decent rate. I mean, if you have a 50-50 chance or something, that's a decent rate. They're also more prone to side effects, and some specific side effects to the spectrum, which would be intensification of ritualized behavior, like getting more stuck, more rigid, having a harder time getting off of something that they'll get over-focused on things when they're taking the medicines for focus. There's a lot of different medicines that belong to this category, and so the way to think about it is that they're all psychostimulants. It's a big group, and these are the mainstay for ADHD. They're certainly something to try for kids with lack of focus and autism. And they have two, within that big group of psychostimulants, there's two subclasses that are still psychostimulants, but one's methylphenidate group, so you've probably heard of Ritalin, that's methylphenidate, and then the other's the amphetamine group, and that you've probably heard of Adderall. The others in the Adderall group are Dexedrine and Vyvanse. There's only 3 members of that group. The methylphenidate group has a lot of members. Like, other than Ritalin, there's Metadate and Methylin and Daytrana patch, and Concerta would be a big one. And Focalin even goes in that group. Focalin's a little bit different, just in that, Ritalin is methylphenidate and Focalin's desmethylphenidate. It's just the way that pharmaceutical companies come up with a new medicine. They take the active half of the medicine and they make it a new thing, which can be good, because I know kids who respond to Focalin and don't do so great with Ritalin, and vice versa. So there's some process of trial and error there. But there's that methylphenidate group. They're equally effective, but it may have slightly less side effects. So it's something to, as far as I'm concerned, it's the first choice to unless there's some big reason to start with the Adderall group, then we start with the methylphenidate group. And then it all depends on each child. Like whether or not we start with short-acting medicine. There's medicine, in that group, there's medicine that lasts 3 or 4 hours. There's also medicine that lasts 8 hours, like it's a time release. There's ones that are divided different, like 50-50 time release, 4 hours apart. 30-70, for more medicine for the late day, because there's every kid's attention wanes anyways over the day, and then they have to pack up, bring the right things home, do all this stuff at the end of the day, and their medicine's wearing out, so sometimes that one is more helpful for some kids. Also, there's ones that last 12 hours, so that's like Concerta. It's actually giving 3 doses. So that isn't usually a choice. So like the child is little and going to bed early, we wouldn't pick that. Like we try to pick something. And the littler they are, the more careful we are. Smaller doses, test doses, looking very carefully for these main effects and side effects, like the main effects of better focus. Like if the child starts to focus more on the movie in their head, not helping, and some that happens, and others it doesn't. Sometimes they become more focused on like being able to hear what the teacher said and what the other kids are saying. So we're looking for that. Yeah, it depends on those thresholds. So there's one little boy who's not on the spectrum actually. He had ADHD. He was 3.5 when I started medicine. For him, that's one time, in all these hundreds and hundreds and hundreds of children. I would say that about the lower border is if we're really having severe problems is 4, because these problems change so much over time with development. There's a reason first grade starts at age 6, because a lot of kids can sit at a desk by the time they're 6. Not all kids can sit at a desk by the time they're 6, and a lot of them still have a lot of trouble with it. And then they're going to have a hard time in school, unless it's a very specialized school. So it's a question of how, like 4 is usually when I even have a question mark in my mind, but then these symptoms have to be pretty big before we even think about it. Yeah. It's often an appealing idea, I would say, and that's again an individual thing, because it all depends on what we know about, like, what are these medicines, what's been the history of these medicines, are they doing anything anymore? Sometimes we really don't know. And then how safe is it? I think if you're going to do a plan where a child is going through their regular day and we're trying to make a drastic change, like taking them off everything, then it would be a slow, gradual taper one by one. So that, and we're thinking again about those main effects and side effects, and keeping really good records of like everything that's happening and what we're tracking, so that we know, like, oh wait a minute, we've had a 50% increase in impulsivity ever since we stopped this medicine that we thought was doing nothing. There's a whole process that's going on in the brain, even, like obviously all these things interact, all the hormonal axes, and, children certainly do change over time. And so I think if you have someone you feel, that you trust, and you could talk through all of that and think about a plan that makes sense, that as long as, I think if we define the plan, and we know what we're doing, as far as like what we're looking for, then sometimes that makes sense, and sometimes it doesn't. Sometimes I've known a kid for years, and I am like 99% certain that this child is going to take if we stop one or another of the medicines, and then I feel really uncomfortable as their doctor saying, well, let's just see what happens. Like maybe it's not doing anything, when I'm reasonably certain that it is. Having said that, I certainly have felt like I was in that position and still made a parent plan to like. And then I want maybe the reduction to be a bit more gradual, or very carefully, where we really defined like what we're considering is reemergence of symptoms. And maybe and maybe not. I mean, I think that would take an entire evaluation, and then,
right.
to decide, like what. I mean, I think you could, like I laid out some criteria that I might think of, for instance, for stimulants. I could do similar thing for anxiety, for instance. Like anxiety certainly is one of the most behaviorally responsive symptoms, except for maybe kids on the spectrum sometimes, when it's just like so ingrained. Some, so the anxiety symptoms are maybe attached to a particular idea that's fairly fixed, or some particular ritualized behavior or something that we may have put in many behavioral strategies and touched it just a little bit, and we're having huge meltdowns over anxiety and that kind of stuff. Then I think, okay, well, that's very clear. Well, what you're talking about, he's not having huge behavioral meltdowns, or he's not having, or maybe he is. I'm not sure, but I'm trying to be full disclosure here. Like, there are side effects. I think about them all the time. Like like whether or not they're justified, or what side effects is this child likely to have. And based on individual children, sometimes I jump over. I don't go to I skip psychostimulants because I am so certain that it's going to make them worse that I don't want to go there. So far, for kids on the spectrum, there's been several reasonably powered studies, meaning it had enough kids in it to see a difference, like if there was a difference, and they didn't find a difference. And they were well-designed studies where they were looking at, blinded observe. There's only so much blinding you can do in a study like that, because of course the child knows what he's eating, and the parents know what he's eating. So it's not you can ask the parents like, we've had your child on a special diet for 2 weeks. What do you think? They don't know what it is. So what they do instead is they have observers behind one-way mirrors looking at the children that are in the study, and they're looking at measures. They're looking at ritualized behaviors. They're looking at motor stereotypies. They're looking at the flapping and any kind of movements that they're doing. They're looking at how focused they are on certain topics. They're looking at their language and their use of language and their social reciprocity. They're looking at all the right things, certainly, and they're doing behavioral scales that look at all kinds of things like impulsivity and irritability and such. And the kids on the diet and off the diet are not statistically different. Because sometimes there's a statistical difference, and in my mind, when I read the study or I see the kids, I'm like, there's no clinical difference. I can't see it. So I think the jury's out. They haven't shown an effect, and maybe it's that there's a subset of kids that would we'd be able to figure out this subset of kids that really. Obviously, if they have a wheat allergy, they're in that group. We need to keep them on. If they have gluten intolerant, they have celiac disease, something like that. But beyond that, I certainly have seen many parents tell, like you said, you didn't see much. I've certainly seen parents who saw, they were convinced there were huge differences. So I don't know what to make of that yet. All I know is the research hasn't been able to show it. And so, maybe we'll know something better about that as time goes on. Yeah. So they're already are really irritable, and they are very rigid already. They have lots of repetitive behaviors. They pick their skin and that kind of thing a lot. These kids who are just already, I almost universally, if I've tried stimulants, all of that got worse. And so I've learned over time to pick out the ones that are most likely to end up worse on the stimulants. And sometimes I'll say, let's do a cautious, half dose trial, see what happens. Maybe I'm wrong. And then after a while I stopped doing that on some of them too. And I said, I'm not going to put you guys through that. It just doesn't make any sense to me. Why do that? And then we'll skip to, I have other medicines here that the next group, that could be a better choice for them. So I have all the side effects here that, can look big and scary. But most of this stuff doesn't usually happen. This is the list, the list they tell you, but I think they're common enough to think about. And we monitor all kinds of things. Kids don't necessarily eat. The common ones are that they don't eat as well, certainly for lunch. Sometimes dinner has to be late because they're not so hungry even when they get home. We have to look at things like high interest foods and putting in some supplements and such sometimes. Because if the kid already has a limited repertoire of foods that they eat, and then they start eating less of them, it can be a problem. So we think about that. Because if the medicine's really benefiting and they're more, focused in class and they're doing better and they're learning more and their social behavior's improved and they're less impulsive and they're functioning better, then I'm going to, really try to work hard on big efforts to get more nutrition in them. And preferably healthful things. But I'll resort to putting, full-fat cream on donuts if that's what's going to happen to get that child, to get some calories in. So, but we watch that, growth in weight. We want to see that they continue to grow on their growth curve, put on weight as expected. The other things are really, really rare. We watch out for things like any family cardiac history, then the child would need, or if the kid has anything, they have autism as a part of a syndrome or something that could have cardiac. Definitely, we're getting cardiac clearance then, and a cardiologist would see the child. There's been people. There's been a debate about getting EKGs on all kids, but the problem is the EKG isn't likely probably to catch most of the problems we're actually looking for. So if we're worried, then that EKG in my mind isn't good enough. So I'm not getting routine EKGs on every kid. I'm looking for the kids who are most likely to have a problem and really getting a cardiologist to look at them and get an echocardiogram and really, if the cardiologist is worried about their rhythm, getting a full Holter monitor, bigger testing if there's a worry. Other kids, it doesn't really pan out to do cardiac testing. So what if either we've bypass stimulants, or we have decided, we've tried several, and either they've had reactions or it's not working so well, we're not getting the main effects, then we could think of non-stimulants. And there's two big things to think of there. One's called Strattera. People have probably heard of that because it's been, around on the market for, probably 8 or more years, more, probably 10 years now. And it was heavily marketed, directly to children on Nickelodeon when it came out, which was lovely. I thought. Slightly making it up. I'm not sure it was Nickelodeon, but it's on TV. Commercials on stations children would watch, and they were like asking their parents, like, "Look, Mom, I need that." And they would come into their appointments with me, "Dr. Nishwala, there's a new non-stimulant alternative for," and I say, "Really? That sounds like a commercial." So, anyways, however, and what happened when Strattera came out, it came out in January, and lots of people, because of this big marketing campaign, were like, "Oh, we want this. It doesn't, you can have refills on it. Like, stimulants need 30-day prescriptions. You have to give the prescription to the pharmacy every month. It's a controlled substance." Strattera, no, you got refills. No control on it. Very convenient. It doesn't have the same side effects profiles. It could cause some decrease in appetite, but not the degree of the stimulants. It doesn't usually keep kids awake. If anything, it makes them a little sleepy. Sometimes we have to actually move it to night because they're so sleepy, or we have to break up the dose or something because they get sleepy. Most don't, but some do. And they might get nauseated. Dizzy, nauseated, sleepy are the big things that I see if I do see something. So every now and then I see a child who gets agitated as well. Just like they can on the stimulants, it's less likely, but it's possible that it could happen on the Strattera as well. So after it came out in January, I waited until the summer, because I thought, well, let's see if it's safe. Just hit the market now. So why would we put a bunch of kids on it? But by the summer, people were still watching those commercials. They wanted it. So I literally one summer switched over probably 300 children onto Strattera because they all wanted it. The parents were like, "Please, can we have it?" I say, "Okay, here's the pros and cons. I don't know what's going to happen." Maybe 25% of them stayed on it. But of that group, spectrum was overrepresented compared to kids with pure ADHD. So I would say that happened. That's not a research trial. That's clinical experience. It's not so scientific, but that's what happened. And of the kids who took it, some were just like, "Wow, this is great. I love it. I feel so much better." They were bothered by this feeling of the stimulant taking hold, or in some way. They just felt subdued or held back by it. It's got to be an uncomfortable feeling. So when I hear that, I think, we need to do something different. It's not good. But, with Strattera, some kids were able to tell me, "I feel really good." And then I had one little 8-year-old girl tell me, I thought she was going to stay on Strattera for her school year, and I started to write her a prescription, and she said, "Oh, no, not that one, Dr. Nishwala. I need my medicine that works. I have to go to school." I said, "Oh, rip." Let's do the medicine that works. Having said that, I've seen many kids who did really, really well on it, too. They were, kids who were just so dreamy that their mom was kind of, steering them. Here we go to the scale. The kid's got a book or something, step on the scale, one leg up, here we go, really just very, very, very dreamy. Now able to sit and actually sit on the couch and tell me what's happening, because they're kind of more focused on here and now and what's going on, as opposed to whatever they have going on in their head. I don't want to make it sound like a miracle. I'm just saying that's the really good outcome. And then there's the intermediate ones, and then there's ones, and I just say it's not doing anything bad, but it's not doing anything noticeably helpful either. So we should just stop it. SSRI, yeah, absolutely. It can be taken with a stimulant too, actually. Even those are compatible. And actually, in that summer of the Strattera 10 years ago, I found out that if you stop the children's stimulants suddenly and just start the Strattera instead, bad things happen. The child is unmedicated for a while. It takes a while for the Strattera to be working. It's not like stimulants that it's on and off. It's got a period of adjustment. You have to start at half the dose to get them used to it, then go up to the treatment dose. And during that time, there seemed to be a number of weeks that they were just uncovered. So I found out that going down slowly on the stimulant while doing that time of getting onto the Strattera went much better overall. And then some kids had a sweet spot right in the middle. They're on a lower dose of stimulant, they're on the Strattera in the background, and they just were functioning really, really well. So I made them Eltamote, and then some of them I put back on their regimen later, because it was really, and I still treat some kids who take that, take Strattera because it works, all through the day. It doesn't have the on-off of the stimulants, if it's working. And then it might be that they're pretty good as far as impulse control and they can focus better, but for school and sitting and learning and listening to the teacher, they need a little bit of stimulant on board, maybe a lower dose than they would without the Strattera. But it's also compatible with SSRIs as far as anxiety symptoms. So the other one, other than Strattera and non-stimulants for like this ADHD picture of particularly the impulsivity and the triad of impulsivity, irritability, and even aggression is the alpha-adrenergic agents, and that's just like what receptors they hit. They really are blood pressure medicines. They were years ago blood pressure medicines, and as things are often the case in medicines, things are discovered accidentally. Thorazine, the thing that cleared out psychiatric institutions in the 1960s, is anti-nausea medicine for post-anesthesia. That's what it is. Like, that was what it was designed for. And then, oh, by the way, people woke up and they weren't hearing voices anymore. Yeah, so it was a good thing. So there's many stories like that in psychiatry, and this is one of those stories. Even stimulants are like that. So they started out as blood pressure medicines. These ones are, not really used as blood pressure medicines anymore. They're really used for this kind of crossover indication of impulsivity, either of ADHD or of other disorders, including autism spectrum disorders. They tend to, since they're blood pressure medicines, you have to go slowly on the dose, like start out at a low dose, make sure the child's tolerating okay, we want to check their blood pressure. Generally, I don't see any blood pressure problems. Like, I very rarely have seen like anything that I would call a medical problem. I saw one boy who came to me and told me, he had a bad reaction on one of these. I saw another child who I thought had it, like over all these years. Other times they just don't tolerate it well either. They're tired is the big one with this group. And particularly the clonidine compared to the guanfacine can cause even more tiredness. Guanfacine lasts longer than clonidine, it's shorter. Both of them have come out in extended releases. The Intuniv is the extended release guanfacine, so 10x is short release, and then the Capve is brand new this year or last year. For the clonidine is an extended release. The clonidine also comes in a patch, so that's one of two patches available in child psychiatry. The methylphenidate has a Detrana patch, so that's a psychostimulant. Clonidine has a patch as well. That it's actually one that you change. It's supposed to be every week, but I don't know that I've ever seen a child that it seemed to last for a week. Like, usually it's about every 4 days or so. You take off one patch and you put on another patch, and then you wear it continually all around the clock for impulsivity. So it doesn't help as much with inattentive symptoms, only in as much that if the inattention is more product of impulsivity, like you're thinking, getting up, moving, thinking of 5 other things, and we quiet that, then you could be more focused because you're spending longer on the thing in front of you as opposed to getting distracted to a lot of stuff. So that, those are also compatible with psychostimulants. Sometimes children will take one of these if they have a lot of impulsivity all through the day. These are the kids who are, the parents turn around for a second and they like have 3 chairs on top of each other and are like getting something, on the rafters or something. It's dangerous. And they may need that as a background because when the stimulants wear off, that's all back, and then the child is really having a hard time. Or if they have like a lot of, one of the symptoms with the psychostimulants like the Ritalin is at the end of the day there could be rebound. Like more impulsivity, like either irritability or impulsivity or like return of symptoms, but bigger than they would have been if we didn't have any medicine on board. So these medicines, like the 10x, could quiet that down too if it's really problematic. Like the stimulant's doing something important and we really need to keep it, then that could help with a bigger picture. So anti-anxiety medicines, generally when we think about anti-anxiety medicines, we're thinking about the group that Prozac belongs to. So that's the SSRIs. Maybe people have heard that. I heard one parent use that term. And this, Prozac was the first one that came out in this country, in this group. Fluoxetine, in 1988. It's been on a long, long time. Many, many kids have been on it. One time it was the most prescribed medicine in the world for any indication, like worldwide. Because when it came out, it was like this revolution because older medicines had so many side effects, and this seemed to be like the side effect free. Like people tolerate it great, it's like let's put it in the water, So it got really maybe overprescribed for a while. This group, the big thing you'll hear in the news is this whole group has a black box warning on it. for suicidal thoughts in children, so, or young people, like meaning under 25. So that's probably a product of the developing brain. The young brain is different than the adult brain in a lot of different ways, and so children as a group are more impulsive than adults. And so somehow giving, increasing serotonin, which we know is in a deficit state in kids with autism. You can measure that, as a group, kids with autism have less serotonin than kids without autism. Like, we know that. So then there's research into that. Like, well, what about that? Should all kids with autism have serotonin, medicines? That's an unknown question. Like, but I don't know the answer to that question. Certainly there's been some studies, like maybe people saw last year, a study on citalopram, where Celexa came out, and that was a study for the repetitive behaviors, and it was a negative study. So at 20 milligrams a day of citalopram, they really didn't see any decrease in the repetitive behaviors. That doesn't mean that another agent in the group, all we know is that particular one at that dose in this study didn't work. So it's certainly something that's tried, but I would say its main indication is the anxiety symptoms, that real intense anxiety of not being able to approach things or getting really anxious and worried about things. Sometimes children on the spectrum have separate anxiety disorder, like it's a fully diagnosable anxiety disorder, like generalized anxiety, like really worried about their abilities and really worried about what other kids think about them, and thinking about that all the time in that same way that a generally anxious kid would, who doesn't have autism. So really then, we would want to try to design the same cognitive behavioral strategies that we would usually in that disorder. And if the symptoms are too big and they're really holding a child back, consider medicine too. Or other anxiety disorders too, obsessive compulsive disorder. I've certainly seen that, like kids with autism have ritualized behaviors, but I've seen kids who have their set of ritualized behaviors and boom, suddenly they have a 500% increase in ritualized behaviors. They have all the classical OCD symptoms. They're washing hands, they're wiping spots on the sink, they're not able to do a routine action like get out of a chair. It doesn't feel, like that's OCD. So they have both autism and OCD. Then you almost always, in that case, depending on language level, medicine would be indicated because we could do behavioral strategies for it, but if we can't talk through the cognitive part, we pretty much have to use medicine to treat those symptoms. So in young people, compared to adults, the biggest thing we watch out for side effects is increase in activation, like a child getting more impulsive. So with the kind of flip side of inhibited is bold. Like now, maybe they're saying anything that comes to mind when they're in the classroom, or they're telling people exactly what they think about them, like their filter just, thank you, their filter just got to 0, So, and I'm not saying that happens for every kid, but I'm very watchful for that. And go really slowly on the dose. And sometimes, especially for younger kids, we'll use liquid medicine and we're going up by drops to watch out very carefully for that. Remember this little boy I was telling you that I argued on the phone with the chairman of the CSE, and he really did have quite a bit of anxiety. So we used one of these medicines, the Prozac, and we dropped. I think he ended up on 6 milligrams. Like a typical dose is 20 to 40 milligrams. He was on 6. It made a huge difference in his ability to function, but he was disinhibited too, even at 6. And we went to 8, and we had to cut back to 6. And then for him, he was having such severe meltdowns, like as far as the entry point may have been anxiety, but he couldn't tolerate the anti-anxiety dose that would have treated that. And so he actually was not only on this small little dose of Prozac, but a whisper of the next category, Risperdal, 0.25 milligrams, combination, so much more. He could tolerate not being first for prayer time anymore, or, whatever, these little things that would come up all through the day and just take him out of the picture, now he could tolerate, and he, over time, now we've been able to, he's a couple years older now, so this went on for a couple years of very low dose, using behavioral strategies, slowly increasing his ability to tolerate things, and now we've been able to stop the Risperdal. He's only on the 6 milligrams of the Prozac, and the next thing will be over time, very slowly. I never, why, there's no real reason that I need to take him right off of this, so I'm going to go really slowly over, a 25% reduction every few months. We'll give it, do 25%, and we'll wait till the end of the school year. how is the summer going? Maybe we'll do another, like that. It will be like over this next year, maybe we'll come off of that 6 milligrams. You know what, kids are really different. That's a really great question, but kids, sometimes, and I always try to gauge them right from the very beginning. I ask them, my children, all kinds of questions to see what they can tell me about. Because obviously I have information from mom and from dad and from their teacher and their therapist and everybody in their life. And then I'll ask the child, like, oh, some children, when they're packing up from school, bring everything home. Some children find that they forget things. How about you? Oh, I'm the one who forgets things. Some of them, I know they forget everything. They're like, oh, I bring everything, Like, really? Okay. Doesn't look that's true, but we'll see. And then we might try to work on, like we might put in some strategies to try to make them more self-aware. Like have them actually check off, like how many, and then show them, oh wait a minute, you thought you brought everything, but actually you forgot your math note folder and, like whatever it was that they needed, and help them understand it. And these are kids on the spectrum or off. I sometimes see kids who have really great verbal skills and they could talk about a lot of things, but they cannot tell me accurately like how they're actually functioning in the world. Or even sometimes how they feel about something. They'll say, or sometimes they just have a hard time, like maybe they've said, like I can get clues from their parents, like their parents will know that they said, I don't like the idea of taking medicine because it makes me feel different. When they come in, they want to be, they want me to think, good things, and so they'll say, it's great, I love it, Say, oh, maybe not so much, and then we can open a dialogue about that because I know something about it. So they're all different. Like I think we have to assess each one, and there's like certain things I'd be looking for. I just want to say that the atypical antipsychotics I think was one of the overprescribed groups of medicines for a while there. It was used too widely for, especially in certain populations like foster children. Just I think because they didn't even have behavioral therapies available to them, and some of these behaviors are, if a child's being aggressive and hurting people or biting, especially biting. They could end up on medication pretty quickly. But this group, the reason I want to mention is the only 2 medicines that actually have an indication for autism. Now, I'm not saying they're to treat autism, but they have a specific indication from the FDA for the irritable, tantruming, and aggressive behavior. They have an FDA indication, and that's the only one out of the group that has an FDA indication for autism. And they certainly can help, not only with those symptoms. I think it's, especially if they're very internally preoccupied, can focus better on this group of medicines. But really, we only use them because of their big side effect profile, and that side effects are metabolic side effects like weight gain, increase in lipids, change in blood sugar. These are concerning things. And then very rarely something called tardive dyskinesia, which is abnormal movements, and I say it's really rare, but it's certainly something that gives me pause, like even a small possibility of abnormal movements. So children with any condition could have a side effect on some of these medicines to have an increase in tics, like that's twitching movements. Tardive dyskinesia is different because it's a different kind of a movement. It's something called a dyskinesia, which may be kind of outside the breadth of this talk, but it's like a tic, like people wouldn't be familiar with a tic, like blinking, for instance, would be a tic. A dyskinesia is often a more, it's called choreoathetoid or writhing kind of movement, like chewing would be like a movement that would be more like a dyskinesia. So there's certainly something we watch for on every single time I see a child when they're not medicated. I'm watching every single motor thing that's going on because I want to catalog all of that. Like because kids on the spectrum and kids with ADHD are more likely to have abnormal movements already, like tics, or even some things that look like these dyskinesias. They might have them already, so we want to watch out for them. But then, we watch, and I've never actually seen it happen. I have to say that I've never seen it happen. I've seen 2 cases where kids had a few dyskinetic movements as we went on that taper down, and then they went away. They've never actually persisted. So, and then tardive dyskinesia is something that persists, and it's usually seen in adults, like adults with, psychotic disorders within 20 years on medicines, and they have to be. So we certainly monitor kids closely. We monitor their weight, monitor their laboratory studies. Like every 6 months, check things like lipids and blood glucose, and make sure chemistries, all of that is normal. Yeah, if you're worried about a medicine, I think coming in specifically with here's some information. I wouldn't not Reams, because then the doctor will just be like, okay, I'll read that later. But if you have something reasonable, they could explain it to you then. Like, okay, you could say, this is why I think it's the medicine. Like, it looks like, there's a 37% chance that my child could get this, and it looks like it's described exactly as they say. Can you explain to me why it isn't? You know, and I can understand. Because maybe it isn't. Maybe it isn't the medicine. Maybe it's something else, and the psychiatrist just hasn't explained it yet. I think if you go through those steps and you've really tried to have a dialogue with them and tell, I'm really concerned about this, and you're not getting the expected response or like some action, then it's time to get a second opinion. You know, whether that's to switch to another doctor or just at least to get another opinion. If maybe another doctor telling them, yes, I think this is actually a side effect, looks like these are 3 other options to consider. Even within a hospital, you have to consent to any medicine that your child takes. So if you're very concerned, you still have that you know, parental right to say, I don't want my child on this medicine. You know, I would be really clear about making sure that you understand exactly what's happening. And even then, I've seen kids for second opinions who are hospitalized. So you're highlighting one of the research difficulties, that most research studies are short. They're weeks, maybe months in length. Maybe some things have been followed more, you know, like antidepressants, for instance. There's like follow-up phases where they're years out now following kids. But what I'd love to see is like full neuropsychological profiles and like exactly what happened and like, you know, brain scans and, you know, like really, like I'd love to see that. It doesn't exist. Like what we do know is we know kids who have taken these medicines and, you know, like, yes, they've been out like years and years. I mean, stimulants have been out like 60, 70 almost years now. You know, like I said, the Prozac group had a precursor group that was out for years before Prozac came out in 1988. So again, but even for Prozac, kids have grown up. They've taken it in the childhood and they've grown all the way up to adulthood now. So we have clinical experience, certainly. I've known kids who've grown up that I continued to treat them as they were adults, whether or not they're on medicine. You know, sometimes they're off their medicine and I've seen what's happened to them. But I don't have, and so I would have, and they might have testing through time. You know, I might have that clinical experience that includes testing, but it's not the same rigor of a research study like looking for differences. It doesn't exist. Risperidone is definitely a psychotropic medicine. It's not a psychotropic medicine. I mean, those are basically all of these medicines are changing something about the way your brain is functioning, and you know, and we could see that on brain scans, for instance. Like there's some medicines are in and out of your system. That'd be like Ritalin, certainly. That group, you take it, it has such a short duration of action that every day it's out of your system again. I mean, Risperidone doesn't have a long half-life, but it has a half-life that it's supposed to be a twice-a-day medicine because its half-life is relatively short. You need to take 2 doses a day to really cover the whole day. I certainly treat kids who take only 1 dose a day because that works for them. But what happens is as a child gets older and bigger, they just may require a different dose. So in the kid, like for instance, the kid with the OCD, he's not completely nonverbal, but he doesn't have language that he could tell me about any of this. Like it wouldn't be helpful to me to gauge the response to the medicine. So again, in those cases, it really is all about the behavioral data, like really keeping, like quantifying, like whether it's the aggression or whether it's the obsessive compulsive behaviors, like how many minutes a day are these behaviors occurring, and then we look for reductions, you know, or in like how hard it is to pull them away from a behavior, for instance. So, and with the aggression, it's exactly the list that I said, that we'd watch for that, and we wouldn't be able to have them tell us, I feel like my body's calmer or something like that. We'd look for signs of that. Sometimes the SSRIs, there actually was a study, and this wasn't in kids on the spectrum, although I wonder, you know, I don't know if some of the kids were actually on the spectrum, but coming out of Japan, a study of kids who were playing, you know, an online game for up to 20 hours a day, you know. And they actually gave them Wellbutrin, which I didn't mention on here because it would be like a little bit more outside of the category, but it's used for addictions. You know, like kids with, adults, Wellbutrin. So Wellbutrin, bupropion, you know, came out in another name, it's not coming, Zyban, for smoking, quitting smoking. It's the same medicine exactly, but it's, yeah, that's the same medicine. So, you know, I would think about something like that for a kid who is really so preoccupied. I can't say I'm doing that routinely, but sometimes we think outside the box when we have a particularly big symptom that we're trying to, you know, sometimes it's taking away all the video games. You know, I realize that's a huge tall order, but I've seen it work. People have looked at some, you know, like what happens to kids when they're playing, and it does change their brain to play. Maybe in some good ways, but in some negative ways too. You know, like it looks like, you know, it looks like peripheral vision increases, for instance, because you're so used to watching things come in from the edge, and you better like shoot that thing at the edge of the screen, so they actually may be better at seeing a car come up on the side or something. But then there's other things that are changing in a more negative direction. I forgot I was going to say too, as far as other than medications, I did put, I put a couple of over-the-counter things, like melatonin is used for sleep, but these last two, the N-acetylcysteine and the inositol, are used for repetitive behaviors. So those I think about for that, and many kids will tolerate them very well. I mean, there's kind of things you can buy over the counter. If you look them up online, Fred Penzel is a psychologist out in Long Island who's written a lot about it, and has like protocols for how you actually take them. Like if you Google his name, Penzel, and OCD or trichotillomania, those are the things he's really writing about, but it's being crossed over and tested now in kids with autism spectrum. And I've seen some results of kids who, in fact, the boy I mentioned with OCD, we put him on the, I think it was inositol, and I actually remember I said he had limited language. He actually started talking more, during this time. I don't know what to make of that. I don't want to oversell something, but it was certainly a remarkable effect. And maybe it's because he was less preoccupied, that he was more available for the language. Omega-3, this I would probably put in the water if I could, because it just seems like it's coming out again and again and again with positive effects. Cultures that eat more omega-3 fatty acids have so many better health indicators than Americans do. For instance, here we're doing a research study to use omega-3 for ticks of Tourette's disorder. It takes pretty big doses, like you see, like these 1,200 milligram doses for like general health and functioning might be up to 3,000 milligrams, 2,000 or 3,000 to get the ticks under control. So there was actually a study that came out last year that omega-3 prevented progression to psychosis too, if you look at that as such a severe thing. And that threshold was 1,300 milligrams a day. And you're looking at the EPA plus DHA on the omega-3, and it should add up to that 1,300 milligrams, and it should be twice as much EPA as DHA. And the good brand is, that's safe, I think, because it's the brand that we used in our study. It's Kirkland that you can get at Costco. Yeah, it's a safe one. So really, I think you have to look at the overall picture, what are all the targets we have here? Things that we need to increase, like their deficits, like of things that the child's not doing, like maybe socializing, or talking enough. And there's things we want to decrease, like impulsivity or anxiety. So we have to think about that, and then look at what are the most impairing symptoms, like what's getting in the way the most of the things that we know this child needs to do. And then as far as what to do about it, cognitive behavioral therapy requires that a child can think things through and has the language to do that. So if that child has the language to do that, and we could test it out. We could you have a hypothesis of how we might expect to help a child think something through, and if they can do it, then great. I would say in the OCD, for instance, though, there's been some research even in preschoolers just reading the book Blink, Blink, Plop, Plop, Why Do We Do Things We Can't Stop? Like it's about farm animals and O.C. Flea is whispering, for the horse to do this, and all these things, and reading it to 3-year-olds, even though you would think, why would they possibly understand the point of the story? OCD behaviors decrease dramatically. So, like hand washing or even hair pulling or, anything compulsive, they might do it a lot less. So I think there's things you could think about, like a social story might be thought of as a bit of a cognitive strategy, you're helping a child think something through, right? So I would think about their language level and try things and see what happens. Always I would think about those, even if I'm considering that if the symptom's big enough and we don't have enough other behavioral tools to get it under control, then we'd be thinking about the medicine and picking the biggest one that's causing the most trouble first. Yeah. So I know I'd love to. You guys have been great. I'm so happy that everybody came and you guys had such great questions. It's been fun. And I hope we'll see you for more. We have more of our series coming with flyers for research studies in case you want to think about, research studies could give, comes with a free evaluation, includes like a ADAS and an ADIR and neuropsych testing and all these things. So.